Hi class, let's continue on as we look at Module 1. We did heart failure. Now we're going to talk about PAD, peripheral artery disease. Specifically, we're going to look at the lower extremities. So what is PAD? It's the progressive narrowing and degeneration of the arteries of either the upper or the lower extremities. Atherosclerosis is the leading cause in most cases, and patients with PAD are more likely to have coronary artery disease or cerebral artery disease. PAD is strongly related to other types of CVD, cardiovascular disease, and the risk factors. And patients with PAD have a significantly higher risk of mortality in general, CVD mortality, and major coronary events and stroke. PAD is a marker of advanced systemic atherosclerosis. So the common sites of atherosclerotic lesions, they're shown in yellow here. Atherosclerosis more commonly affects certain segments of the arterial tree, as we call it. And you look here, it kind of sort of looks like a tree. These include the coronary, carotid, and lower extremity arteries. Clinical symptoms occur when the vessels become about 60 to 75% blocked. So someone may not know that they have PAD or atherosclerosis. They're two different things. Until the artery is over half blocked. So this is why we need to carefully educate and look at patients who are at risk for development of atherosclerosis. The risk for PAD increases with age, and individuals usually become symptomatic in the 6th to 8th decades of life. In persons with diabetes, PAD occurs much earlier, and PAD prevalence is higher in those of lower socioeconomic status women and African Americans. It is largely undiagnosed until things get pretty bad. Remember that 60 to 75% blockage. Nicotine is a vasoconstrictor, and tobacco smoke impairs transport and cellular use of oxygen and increases blood viscosity and homocysteine levels. Other risk factors include elevated C-reactive protein, family history, high triglycerides, increasing age, like I said, hyperhomocystinemia, hyperuricemia, obesity, sedentary lifestyle, and stress. Remember, stress affects every part of our body because of the release of cortisol. And this is why we should be teaching our patients about stress reduction with anytime that we're doing education. Throw in something about stress reduction. And remember for yourself to reduce stress and find ways to take care of yourself and make sure that you are taking time to relax and unwind. Now, peripheral artery disease may affect the iliac artery, femoral artery, popliteal, tibial, and peroneal arteries. The femoral popliteal area is the most common site in non-diabetic patients. The patient with diabetes tends to develop PAD in the arteries below the knee. In advanced PAD, multiple levels of occlusions are found. So, the ischemic pain that happens because of this constriction of blood flow is resulting from what we call an intermittent claudication. The ischemic pain that is caused by constant level of exercise resolves within 10 minutes or less with rest and is reproducible pain. But the pain is a result of the buildup of lactic acid resulting from anaerobic metabolism. Once a patient stops exercising, the lactic acid is cleared and the pain subsides. PAD of the iliac arteries produces claudication in the buttocks and thighs, whereas calf claudication indicates femoral or popliteal artery involvement. As many as 1/3 of patients with PAD report classic claudication symptoms. The remaining either have no symptoms or present with atypical leg symptoms, such as burning, heaviness, pressure, soreness, tightness, weakness, etc. And they do this atypical pain in atypical locations, such as the ankle, foot, hamstring, hip, knee, shin. The remaining have, like I said, those atypical leg symptoms in atypical areas. Older women experience classic claudication less often than men. Paresthesia results from nerve tissue ischemia, and that's numbness or tingling in the toes or feet, produces loss of pressure and deep pain sensations, and injuries often go unnoticed by patients. Now, this should sound a little bit familiar because, diabetic patients have similar symptoms. That's called neuropathy. But true peripheral neuropathy occurs more often, like I said, in patients with diabetes. And you can learn more about that in Chapter 48. And in those with longstanding ischemia. Neuropathy produces severe shooting or burning pain in the extremity. And this is from nerve tissue ischemia. Gradual, reduced blood flow to the neurons produces loss of both pressure and deep pain sensations. Thus, patients may not notice lower extremity injuries. This is why we tell diabetic patients to check their feet regularly for any signs of any sort of injury. True peripheral neuropathy occurs more often with diabetes, so we need to educate early on for those that are at risk for developing diabetes, the pre-diabetics before they have a full-fledged disease, so that they know about this. Now, this pain does not follow any particular nerve roots and may present near ulcerated areas. So, we're looking at basically loss of sensation or an overriding tingling or burning pain that, or many of the diabetics call it, my feet are always cold. Feels like my leg is in ice. So if you hear your patient saying that, they're experiencing paresthesia. And then we need to figure out why. And of course, the answer in many patients is diabetes. Clinical manifestations of PAD, thin shiny and taut skin. There's loss of hair on the lower legs. There's diminished or absent pedal, popliteal, and or femoral pulses. Pallor of the foot with leg elevation. Pallor is the blanching of the foot, develops in response to leg elevation, which is called elevation pallor. We get so creative with names. Conversely, reactive hyperemia, redness of the foot, develops when the limb is in a dependent position, or what we call dependent rubor, R-U-B-O-R. As PAD progresses and involves multiple arterial segments, continuous pain develops at rest. Rest pain most often occurs in the foot or the toes and is aggravated by limb elevation. Patients often try to achieve pain relief by dangling the leg over the side of the bed or sleeping in a chair to allow gravity to maximize blood flow. So, in other words, it's caused by this insufficient blood flow, and it occurs more often at night. If you think about it, we're sleeping, we're horizontal. That's why people many times will sleep in a chair with their legs down, because it helps relieve that pain. I love these pictures. So here we have peripheral vascular disease, arterial versus venous. And so I want you to pause on this and take a good look at this picture and even take a screenshot of it. It's a really good description of the difference between arterial and venous. Now we have critical limb ischemia. Patients with PAD who also have diabetes, heart failure, and a history of a stroke are increased risk for critical limb ischemia, which is characterized by that chronic ischemic rest pain lasting more than 2 weeks and arterial leg ulcers or gangrene. Arterial ischemic ulcers most often occur over bony prominences on the toes, feet, and lower legs. There's atrophy of skin and underlying muscles, the delayed healing, wound infection, tissue necroses, and arterial ulcers. Now, this picture, of course, is at the extreme, but we always have to remember the extreme so that we remember to find it early or prevent it. If PAD is present for an extended period of time, collateral circulation may prevent gangrene of the extremity. Uncontrolled pain and severe spreading infection are indicators that an amputation is needed in individuals who are not candidates for revascularization. Amputation is always the last choice. We don't want to just be cutting off people's toes or foot or leg, but it may be the needed thing to do when these infections are non-healing and they have uncontrolled pain. Now, when palpitation of a peripheral pulse is difficult because of severe PAD, the Doppler can determine the degree of blood flow. So, segmental blood pressure, Doppler ultrasound can be used. Also, ankle brachial index, ABI, which is done with a handheld Doppler. A palpable pulse and a Doppler pulse are not equivalent, and the terms are not interchangeable. So remember. They say I can palpate the pedal pulses, or I had to use a Doppler to find the pulses. They're not the same thing. Segmented blood pressure, or blood pressures, I should say, are obtained using Doppler ultrasound and a blood pressure cuff at the thigh, below the knee and at ankle level, so the segments there, while the patient is supine. A drop in segmental blood pressure of greater than 30 millimeters of mercury suggests PAD. It's not an absolute test, but it is very suggestive of PAD. The ABI is calculated by dividing the ankle systolic blood pressures by the higher of the left and right brachial blood pressures, systolic blood pressure. A normal ABI is 0.91 to 1.3 and indicates adequate blood pressure in the extremities. An ABI between 0.71 and 0.90 indicates mild PAD. 0.41 to 0.7 indicates moderate, and less than 0.4 indicates severe PAD. Angiography and magnetic resonance angiography really shows and discovers the location and the extent of the PAD. Sorry about that. I had to take a little drink of water. As you can tell, I have a bit of a frog in my throat today. Table 37.2 summarizes the interprofessional care of the patient with PAD. Because of the high risk of MI, ischemic stroke, and CVD-related death, the first treatment goal is to aggressively modify CVD risk factors in all patients with PAD regardless of the severity. Tables 10.4 and 10.6 discuss smoking cessation strategies, because that's one of the first things that we're going to talk to patients about who have vascular disease of any type. Stop smoking and stop being around people that smoke, because it's not only the primary smoke, it's that secondary and tertiary exposure to cigarette smoke that also influences this PAD. Diabetics are at a major high risk for PAD and increases the risk of amputation. It is recommended that diabetic patients maintain an A1C below 7.0% and optimally as near as possible to 6.0. Aggressive lipid management is essential. To manage lipids, both dietary and drug therapy are needed. Statins such as simvastatin lower LDL and triglyceride levels and thus reduce CVD morbidity and mortality risk. Interestingly enough, with diabetics, there is a growing research body that is saying that the patient should be treated with statins even before they have any indication of hyperlipidemia, because the risk of development is so high and symptoms other than blood work are very, very late in the disease progression. So you may see a diabetic with a statin drug ordered, but what And you look at labs and go, hey, I wish my lipids looked like this. That's because many doctors are already ordering statins to begin with. Now remember, in PAD, patients with coexistent diabetes mellitus or renal insufficiency, blood pressure less than 130/80 is recommended. So again, aggressive blood pressure management. A lot of these numbers, because this was copyrighted in 2017, there's been a lot of data coming out in the last 5-6 years that suggests that this 140/90 should not be the high point. It needs to come down lower. So always stay up on your evidence-based practice issues. Now, angiotensin converting enzyme, or ACE inhibitors, are used for symptomatic patients with PAD. Lifestyle changes are encouraged and include reducing dietary sodium and following the DASH diet. ACE inhibitors decrease cardiovascular morbidity, decrease mortality. It's there to help increase peripheral blood flow, increase ABI, and increase walking distance. Antiplatelet agents, such as aspirin or Plavix. Guidelines for oral antiplatelet therapy, aspirin 75 to 325 milligrams daily. Aspirin intolerant patients may be put on Plavix 75 milligrams daily. Now, drug alert. Plavix and Prilosec. The antiplatelet effect of Plavix is reduced by about half when given with omeprazole or Prilosec. This increases the risk of MI and stroke. So we have to look carefully at the drugs that our patients are taking and look for these drug alerts, these bad interactions, so that we can alert the physician. Sometimes, they go to a heart specialist and they order Plavix, and then they've seen their PCP who put them on aspirin, and they see somebody else who put them on omeprazole, and we've got all of these going on. Polypharmacy plus drug interactions are a great risk factor for many of our patients. Drugs prescribed for intermittent claudication include Platol, which inhibits platelet aggregation and increases vasodilation, or Trentol, which improves the deformability of the RBCs and WBCs and decreases fibrinogen. Platol is contraindicated in patients with heart failure of any severity. So if we have a patient with intermittent claudication and who has heart failure, they cannot take the Platol. Exercise therapy. A supervised exercise program is recommended as an initial treatment modality for all patients with intermittent claudication. Exercise should be performed for 30 to 45 minutes per day, 3 times a week for a minimum of 3 months. Although walking is most commonly prescribed exercise for PAD patients, alternate modes such as cycling also improve walking ability and quality of life in patients with PAD. Overall, patients with PAD who have higher levels of daily physical activity also have better survival rates. nutritional therapy is very important with PAD. Not only are we looking at decreasing salt and using the DASH diet, even modest sustained weight loss of 3 to 5% yields important reductions in triglycerides, glucose, A1C, and if they haven't developed diabetes yet, decreases the risk of developing diabetes. Greater weight loss produces greater benefits. So what we want to do is educate our patients. If we have somebody who is morbidly obese, providing them, hey, you've got to lose 200 pounds. That's very overwhelming. Talk to them about this modest sustained weight loss. Can we work on losing 10 pounds, and then another 10 pounds, and take it segmentally? Remember, short-term goals that lead into long-term goals. Patients taking antiplatelet agents, NSAIDs, anticoagulants should consult with their healthcare provider before taking any dietary or herbal supplements due to the potential interactions and bleeding risks. This goes back to taking a very good health history. Well, what medicines are you on? And they think prescription. Then I would go on and ask the patient, do you take any over-the-counters? Oh yeah, I take Tylenol and Benadryl and, Do you take any herbal supplements? Oh yeah, I take, X. And the X might be a big risk factor. Critical limb ischemia is a condition characterized by chronic ischemic pain lasting longer than 2 weeks. Treatment of this includes revascularization via bypass surgery, and there's a little picture here. They could do PTA, which is percutaneous transluminal angioplasty. It could be IV prostanoids, spinal cord stimulation, or angiogenesis. The gold standard, or the preferred optimal therapy, is the bypass surgery. Sometimes it's not feasible, so they move down to PTA and so on. Patients with critical limb ischemia who are not candidates for surgery or PTA then move on to the IVs, and those drugs decrease rest pain and improve wound healing. Spinal cord stimulation may be helpful in managing pain and preventing amputation. And growth factors and gene and stem cell therapy may be used to stimulate blood vessel growth. And a lot of the stem cell therapies are still being considered as experimental by insurance companies. So it's really important that not only do we know what we might need to do for this patient, but to be able to work with social work, work with the case manager, so that the doctor's not ordering therapies that the insurance company won't cover. Carefully inspect, cleanse, and lubricate feet to prevent cracking of the skin and infection. So this is one of those conservative treatments. We want to protect the extremity from trauma. We want to decrease that ischemic pain. We want to prevent or control infections and improve arterial perfusion. So, diabetics or those people with critical limb ischemia should be checking their feet regularly, washing their feet, putting lotion on their feet. If ulceration is present, keep the affected foot clean and dry, and cover any ulcers with dry, sterile dressings to maintain cleanliness. Obviously, bring that to the attention of the physician, and many times they bring in wound care to decide how to treat this. Deep ulcers can be treated with a variety of wound care products, but healing is unlikely without increased blood flow. Systemic antibiotics are used in patients with critical limb ischemia, skin ulcerations, and limb infection. We also want to encourage our patients to select soft, roomy, and protective footwear and avoid the extremes of heat or cold, which is kind of laughable if you live in Minnesota or Arizona. You've got the extremes there. Summer 115, 120 possibly. Minnesota minus 40 or wherever in the Midwest. So we teach them to get the proper footwear, wear good socks that don't constrict the extremity, and have the most heat-resistant or heat-conserving warm footwear, depending on where they're at. We're looking at interventional radiology procedures. These procedures take place in the cath lab rather than an OR. Determining which intervention to use depends on blockage location, along with lesion type and severity. Pre- and post-procedure nursing care is the same as for a diagnostic angiography. Antiplatelet agents are needed post-procedure to reduce the risk of restenosis, so long-term low-dose aspirin therapy or Plavix is recommended. PTA, percutaneous transluminal angioplasty. Stents, expandable metallic devices, are positioned within the artery immediately after this balloon angioplasty is done. The stent acts as a scaffold to keep the vessel, the artery, open. Both angioplasty balloons and peripheral stents may be coated with a drug-eluting agent to reduce the risk of restenosis. These drugs work by limiting the growth of new tissue in the treated stenotic area and improve long-term patency rates. Atherectomy, removing of the obstructing plaque. A directional atherectomy device uses a high-speed cutting disc that cuts long strips of the atheroma. Later atherectomy uses ultraviolet energy to break up the atheroma, and other types of atherotic catheters have a diamond-coated tip that rotates at a high speed, similar to a dentist's drill. In combination with the angioplasty, the PTA, we can also include cold therapy or liquid nitrous oxide. Expansion of the gas results in cooling to 14 degrees or minus 10 Celsius. The cold temperature limits restenosis by reducing the smooth muscle cell activity. So basically, they go in and freeze the area. Now, interprofessional care surgery treatment. Surgery is indicated in patients with long areas of stenosis or severely calcified arteries. When possible, peripheral artery bypass surgery should be done with an autogenesis vein to bypass, to carry the blood around the lesion. Synthetic grafts typically are used for long bypasses, such as an axillary femoral bypass, when a person's own vessel is not available. Human umbilical veins are a composite segmental bypass graft, which is a native vein plus synthetic graft, is also another alternative. So here we get a look at bypass grafts. A shows femoral popliteal bypass, and that is a graft that goes around an occluded superficial femoral artery. And then the femoral posterior tibial bypass graft around occluded superficial femoral, popliteal, and proximal tibial arteries. So these long grafts can reestablish quality blood flow. Endarterectomies involve opening the artery and removing the obstructing plaque. Patch graft angioplasty is opening the artery, removing the plaque, and sewing a patch to the opening to widen the lumen. So an endarterectomy is they go in, take out the plaque, sew it up. And then a patch graft is they go in, remove the plaque, and then add some material there to make the lumen wider. Amputation may be required if tissue necrosis is extensive, gangrene or osteomyelitis develop, or all major arteries in the limb are blocked, precluding the possibility of successful surgery. And amputation is discussed in Chapter 62. We need to know the patient's past health history. Does diabetes run in the family? Have they ever been diagnosed with diabetes? Do they smoke? Are they around a smoker? Hypertension, lipidemia, obesity. Even if they've lost the weight, previous obesity can still be that risk factor. So we need to know these. We need to look at exercise intolerance, look at loss of hair on legs and feet, decreased or absent peripheral pulses, and for that intermittent claudication sensations that the patient has. Ineffective peripheral tissue perfusion is one of the diagnoses. So ineffective peripheral tissue perfusion related to deficient knowledge of contributing factors. Activity intolerance related to imbalance between oxygen supply and demand. Chronic pain related to ischemia, inflammation, and swelling. Ineffective health management related to lack of knowledge of disease and self-care measures. Now change those around for the appropriateness for your patient. And remember to always add the as evidenced by. The overall goal for patients with PAD is adequate tissue perfusion, reduce the pain, increase exercise tolerance, that they have intact, healthy skin on extremities, and they have increased knowledge of disease and treatment plan. Because remember, if we teach them and get them to buy into the treatment plan, then they're more likely to follow it. And this is teaching, not just giving them the information, but ensuring that the patient knows this information. So how do you make sure a patient knows? You could do a teach back. You could ask them to explain it back to you. Have them identify the meds and why they're using them. There's all sorts of ways to make that interactive so that the patient increases their knowledge and increases the cooperation of the patient in the treatment phase. So health promotion. Assess patients for CVD risk and provide instructions on how to control them. And you want to look at tables 33.2, 3, and 4. Want to teach them diet modifications. We need to be aware of the cultural aspects of diet. We want to reduce the intake of cholesterol, saturated fats, refined sugars. We want to teach them about proper care of the feet and avoidance of injury to the feet. And we want to encourage patients with positive family histories of cardiac, diabetes, vascular disease to obtain regular follow-up care. Even if they have no symptoms, remember back to the beginning, 60 to 75% occlusion before symptoms are often seen. Nursing management implementation in the acute care setting, frequent monitoring after surgery. We're going to do those CMS checks. Loss of palpable pulses or change in the Doppler sound over a pulse requires immediate notification to the healthcare professional and prompt intervention. This is true not only with this type of surgeries where we're dealing with vessels, but orthopedic surgeries. If there's a loss of pulse or change in Doppler sound. After the patient leaves the recovery room or the recovery area, they'll continue to monitor perfusion, assess for potential complications. Those complications can be bleeding, hematoma, thrombosis, embolization, and compartment syndrome. Dramatic increase in pain, loss of previous palpable pulses, extremity pallor or cyanosis, decreasing ABIs, numbness or tingling, or a cold extremity suggests blockage of the graft or the stent. If edema develops, position the patient supine and elevate the leg above heart level. Walking even short distances is desirable. The use of a walker may be helpful, especially with our frail and elderly patients. In ambulatory care, we want to continue to help the patient manage their risk factors. Continued tobacco use dramatically decreases the long-term patency and increases the risk of an MI or a stroke. So we want to continue to support the patients in their goal of eliminating tobacco use. Long-term antiplatelet therapy with aspirin or Plavix is recommended. Explain that exercise decreases CVD risk factors, improves hypertension, hyperlipidemia, obesity, and glucose levels, and make sure you're teaching meticulous foot care. Tell patients to inspect their legs and feet daily for mottling, M-O-T-T-L-I-N-G, mottling, changes in skin color or texture, and reduction in hair growth. Show patients how to check skin temperature and capillary refill to palpate their pulses. Stress that they must report any changes in these findings or development of ulcers or inflammation to their healthcare professional immediately. And it's important to have them make sure that they have good shoes. And these comfortable shoes should have rounded toes and soft insoles. So nursing management evaluation, adequate peripheral tissue perfusion, increased activity tolerance, effective pain management, and knowledge of disease and treatment plan. Plans for a walking program. The walking program can be something that is very regimented or less so. Some people join the Silver Sneakers Club, for instance, and they walk with people around like a mall or a rec center. We want to have them increase that activity tolerance and verbalize the key elements of their therapeutic regimen, knowledge, treatment plan, how to reduce risk factors, and proper ulcer and foot care. So let's take a look at acute arterial ischemic disorders now. Acute arterial ischemic disorders are sudden interruption in arterial blood supply to tissue, organ, or extremity, and if untreated can result in tissue death. Causes could be emboli, thrombus, trauma, could be related to ineffective endocarditis, or infective, not ineffective, infective endocarditis, mitral valve disease, AFib, etc. Non-cardiac causes could be aneurysms, plaque, endovascular procedures, and venous thrombi. So we use the 6 P's for clinical manifestation: pain, pulse, paralysis, pallor, paresthesia, and pressure. Immediate intervention is needed to avoid ischemia, necrosis, and gangrene. Remember, paralysis is a late sign. Early diagnosis and treatment, it could be a percutaneous catheter-directed thrombolytic therapy with something like alteplase or urokinase, which are preferred in arterial ischemia and when that is less than 14 days old. Thrombolytics dissolve the clot over 24 to 48 hours and requires that close monitoring or catheter position and bleeding at insertion site. Surgical revascularization, such as trauma or arterial blockage, amputation, ischemic rest pain and tissue loss, and long-term anticoagulation is recommended if risk for further embolization exists. So let's look at Buerger's disease. This is non-atherosclerotic segmental recurrent inflammatory disease of the small and medium arteries of the veins of the arms or legs. Most common in men younger than 45 years old with a history of tobacco or marijuana use without other CVD risk factors. The acute phase, inflammatory thrombus blocks the vessel. Chronic phase is when the thrombus and fibrosis causes the ischemia. And the symptoms are, as you see, intermittent claudication of feet, hands, or arms, rest pain, ischemic ulcers, etc. Remember cold sensitivity. There's no specific lab or diagnostic test, and the diagnosis is based on history and symptoms with the exclusion of other disorders. Treatment is to stop smoking, no use of marijuana, and no nicotine replacement. Conservative treatment includes avoiding cold exposure, walking program, antibiotics for ulcers, analgesia for pain, and avoidance of trauma. Here we see more treatment options, including IV iloprost, which promotes vasodilation, surgery, and stem cell therapy. Raynaud's syndrome, or phenomenon. This is an episodic vasopathic disease of the small cutaneous arteries in fingers and toes. More common in women, and age of 15 to 40 years. Doesn't mean other people can't get it, but this is the most common age group. Pathogenesis is the abnormalities in vascular, intravascular, and neuronal mechanisms that cause vasodilation. Raynaud's or Raynaud's, whichever person you talk to, phenomena may occur alone or in combination with other diseases. Contributing factors: use of vibrating machinery, work in cold climates, exposure to heavy metals, and high homocysteine levels. Diagnosis is persistent symptoms for at least 2 years. Characteristic changes in color of hands, the fingers, especially toes, ears, and nose. It could be red, white, or blue. Coldness, numbness followed by throbbing, aching, pain, tingling, and swelling. This can last for several minutes to hours. Prolonged, frequent attacks cause thick skin, brittle nails, punctate lesions, and gangrenous ulcers. And most often the trigger is exposure to cold, but may also include emotional upset, tobacco use, and caffeine. So here we see Raynaud's phenomenon in the fingers of this person. We need to give patient education on ways to prevent episodes, such as avoiding temperature extremes, wearing appropriate clothing, no tobacco, avoid caffeine, and no vasoconstrictor drugs. Drug therapy could be sustained release calcium channel blockers to decrease vasospasms and possibly vasodilators. When digital ulceration or critical ischemia occurs, prostacyclin infusion, antibiotics, surgical debridement, Botox, statins, and sympathectomy. Acute and chronic venous disorders: phlebitis, which is the acute inflammation of the walls of small cannulated veins of the hand or arm, related to IV catheter. That's why we inspect the IV site multiple times a shift in order to make sure that our patient is not starting a little redness around the IV site. It could be pain, tenderness, warmth, erythema, swelling, and a palpable cord, resultant of irritation from the catheter, irritating drugs, and catheter location, most often if the catheter is located in an area of flexion. Here's an excellent picture of a poor person that's gotten phlebitis from their IV. The good news is phlebitis is rarely infectious. The treatment is removing the catheter, elevating warm, moist heat, and NSAID. Also look at venous thrombosis, which is the formation of a clot with vein inflammation. This is the most common venous disorder. It involves superficial vein thrombosis, or deep vein thrombosis, or DVT, or venous thromboembolism, VTE, and DVT to pulmonary embolism, or PE. The clot breaks off, goes somewhere, and an inflammatory response occurs. So we see here how the clot is formed and the inflammation that is beginning to occur. VTE causes, well, first, venous stasis is the dysfunctional valve, inactive extremity muscles. People at risk for venous stasis are those that are obese, pregnant, chronic heart failure, AFib, traveling long trips without exercise, prolonged surgery, or prolonged immobility. Hypercoagulability occurs with many disorders: anemia, polycythemia, cancer, nephrotic syndrome, high homocysteine levels, coagulation disorders, sepsis, drugs such as corticosteroids and estrogen, and smoking. Highest risk includes women who use tobacco, because smoking increases plasma fibrinogen, homocysteine levels, and activates intrinsic coagulation pathway. Women that are childbearing age and take estrogen-based oral contraceptives for any reason, postmenopausal and take oral hormone therapy, age over 35, and a family history of VTE. Manifestation, well, these involve the deep veins of arms or legs, pelvis, vena cava, and pulmonary system. You could have unilateral edema. Now, we have to differentiate unilateral edema from VTE with those that are related to a condition such as lymphedema. Good history taking is important. So we got unilateral edema, pain, tenderness with palpation, dilated superficial veins, a feeling of fullness in the thigh or calf, paresthesia, redness, warm, and a fever over 100.4 degrees Fahrenheit or 38 degrees Celsius. If the clot, the VTE, is in the inferior vena cava, legs are edematous and often cyanotic. With the superior vena cava, similar symptoms of arms, neck, back, and face. And we have to remember that some patients are completely asymptomatic. That makes it even harder to do the proper quick interventions that need in order for the VTE not to break up further and cause difficulties such as an MI or a stroke. VTE diagnosis is done through assessment. They run a D-dimer, which of course is blood work. Elevated D-dimer can mean a DVT is present or a VTE. To really know if that, in order to diagnose, is the use of the ultrasound. And ultrasound to the affected area can be quite painful for the patient. So we need to do patient education before they go off to have their ultrasound. The most serious complication, obviously, is PE, chronic thromboembolic pulmonary hypertension, post-thrombotic syndrome, and phlegmasia coeruleus dolens. Say that 5 times really fast. PTS occurs in 8 to 70% of patients. Chronic inflammation and venous hypertension, damage to vein walls and valves, venous valve reflux, persistent venous obstruction. Manifestations would be persistent edema, spider veins, venous dilation, redness, cyanosis, increased pigmentation, eczema, pain during compression, white scar tissue, venous ulceration with severe PTS. The signs may occur in a few months or years. Risk factors include persistent leg symptoms for more than 1 month after VTE, The VTA would be proximal location, extensive, and recurrent. Residual thrombus, and other things to be aware of that increase the severity: old age, poor INR control, tobacco use, increased D-dimer, increased inflammatory markers, varicose veins, and asymptomatic VT. Post-thrombotic syndrome, PTS. Talked about that. But VTE diagnostic studies, blood work as we see here, non-invasive venous, such as venous compression, ultrasound, duplex ultrasound, and invasive venous, which includes CT venography, MR venography, and contrast venography. Early and aggressive mobilization. If the patient has to be on bed rest, and many of them are initially, until we are able to intervene enough to get that emboli to start breaking apart, if we will. Remember to reposition every 2 hours, flex and extend feet, knees, and hips every 2 to 4 hours while awake. Get them out of bed to the chair, and we want to walk them 4 to 6 times a day while they're in the hospital. Now, intermittent pneumatic compression devices help increase venous return, and they are very helpful. External pressure from the electric pump inflates sleeves or boots to compress calf or thigh and or foot and ankle. We need to make sure that they are using them whenever they're in bed. We also want to use graduated compression stockings. Make sure that they are fitted and applied correctly. This involves, again, patient education and family education as a part of their discharge instructions. Wear continuously except for bathing, skin assessment, and ambulation. Do not use with active VTE because of the risk of PE. Drug therapy. Vitamin K antagonists, warfarin, which inhibits vitamin K dependent coagulation factors for long-term or extended anticoagulation. This takes 2 to 3 days to become effective and often overlap with parenteral anticoagulation for about 5 days. Monitor the INR, and the antidote is to give vitamin K. Warfarin should not be taken with antiplatelet drugs or NSAIDs. There are many interactions, so we want to do a lot of teaching about avoiding vitamin K in the diet because that alters the INR. And vitamin K is found in green leafy vegetables, and this can cause altered response to the therapy. So instructing the patient on a proper diet is very important. Other drug therapies include heparin and Lovenox may be used, enoxaparin, which is Lovenox. This is low molecular weight heparin. Heparin itself has these long chains in the makeup of the drug. Heparin has to be very carefully monitored, a lot of frequent blood work. So there's a high risk of non-compliance with heparin therapy once a patient is discharged. The most serious side effect is heparin-induced thrombocytopenia and osteoporosis. So there's been these low molecular weight heparins coming out, and Lovenox has been out for years now. The nice thing about this is it's more predictable, has a longer half-life, fewer bleeding complications. Also, remember that any drug that we give can have a patient allergic to it. Enoxaparin used to be thought of as, oh, nobody's allergic to it, and there's growing literature on the fact that, yes, any foreign substance we bring into the body can cause an allergic reaction. The antidote for enoxaparin, or Lovenox, is protamine. Other drug therapies, as we see, Angiomax, argatrobin, factor XA inhibitors, interprofessional care, anticoagulant therapy for VTE treatment, maintained an INR of 2 to 3. Thrombolytic therapy for VTA, such as TPA or urokinase, administered via catheter to dissolve clots, reduce acute symptoms, improve deep venous flow, reduce valvular reflux, and decreases PTS. Surgery and interventional radiology therapies can be an open venous thrombectomy and the inferior vena cava interruption devices. These are filters placed via right femoral or internal jugular veins to act as traps for the clots without impeding blood flow. So think of these, nets, and certain things can get through, but a clot cannot. Complications are emboli, improper placement, filter migration, perforation of the vena cava, and retroperitoneal bleeding, and of course clogged filters. Here we see an option for cutaneous endovascular interventional radiology procedures. An option would be mechanical thrombectomy, pharmacomechanical devices, post-thrombus extraction, angioplasty, and or stenting of the vessel. Can be used with catheter-directed thrombolytic therapy. What nursing care is involved in is maintaining catheter systems, monitor for bleeding, embolization, impaired perfusion, and teach, including VTE prevention. Obviously, the nursing assessment, subjective and objective data. I've stressed about knowing their health history. Objective data, general, integumentary, cardiovascular, and any diagnostic findings. Here we see a diagnosis of acute pain, impaired tissue integrity, impaired mobility, risk for bleeding, and the goals, of course, are pain relief, decreased edema, no skin ulcerations, no bleeding complications, and no evidence of a PE. Acute care focused on prevention of thrombi and reduction of inflammation, monitor anticoagulation and significant lab studies, monitor and reduce the risk of bleeding. Acute VTEs have initial care of bed rest, early ambulation, and teach importance of physical activity. Ambulatory care, a lot of discharge teaching, VTE risk, drug doses, actions, side effects. We want them to wear a medic alert ID if they are on these medicines, and give them the guidelines for follow-up. Evaluation is expected outcomes should be minimal to no pain, intact skin, increased knowledge, no signs of hemorrhage or occult bleeding. Also, we need to remind them not to take aspirin or NSAIDs and to limit alcohol if they are on these quote-unquote blood thinners. Varicosities. Varicose veins. Their superficial veins in the leg become dilated and tortuous, with retrograde blood flow and increased venous pressure. We see these knotty-looking, twisty veins in the back of the legs. That's the most common place for them. And they are tough. They are what we call tortuous. Risk factors include family history, being a woman, tobacco use, aging, obesity, woman that has had multiple children, history of VTE, venous obstruction, phlebitis, leg injury, prolonged sitting or standing. Most commonly, patients complain of heavy, achy feeling or pain after standing or sitting for a prolonged period of time. And they get relief by walking or limb elevation. Other symptoms could be feeling pressure, itchy, burning, tingling, throbbing, and a cramp-like sensation. Most common complication is superficial venous thrombosis. Some others could be a rupture of the varicosity, resulting in bleeding and skin ulceration. Diagnostic is through examination and a duplex ultrasound. Usually, we should be starting with conservative treatment, rest, graduated compression stockings, leg strengthening exercises, and weight loss. Drug therapy includes venoactive drugs. Interventional and surgical therapies include sclerotherapy ablation, transcutaneous laser therapy, and endovenous ablation. There are other things that many people will look at, and that is OTCs from plant extracts. Not FDA approved, but available OTC as herbal and dietary supplements include apples and grape, which is proanthocyanide, and ruscus, which is butcher's broom, and others. Here we see what varicosities look like. Interventional and surgical therapies include ligation of vein and branches, ambulatory phlebectomy, transilluminated powered phlebectomy, and that complications include bleeding, bruising, and, as with any intervention, infection. Teaching of the patient, how to prevent it, and then for those that are post-operative, deep breathing, neurovascular assessment, elevation of legs, and those graduated compression stockings. Remove every 8 hours for a short time, then reapply. We want to give not only the leg a rest and the foot, and make sure that the wrinkles are out. We want to inspect the skin, provide skin care to the person's leg, and then reapply. Long-term management is aimed at improving circulation and appearance, relieving discomfort, And then, of course, patient teaching. Chronic venous insufficiency and venous leg ulcers. CVI is an abnormality of the venous system, and it includes edema, skin changes, and venous leg ulcers. The etiology and pathophysiology: primary varicose veins and PTS, ambulatory venous hypertension. This is when serous fluid and RBCs leak, results in edema and chronic inflammation. Hemosiderin, which causes the brown skin discoloration, and the skin becomes hard, thick, and contracted. CVI also puts a patient at high risk for venous ulcers. So clinical manifestations and complications include brown, leathery, and edematous skin, eczema with itching and scratching, where scratching causes the skin to be opened up, and venous ulcers, such as what you see here, which we are aimed at pain management and managing the risk of infection. Stockings, bandages, IPCs, wraps, teaching the patient and or family member proper fit and application, and assess for PAD prior to compression. Avoid prolonged sitting, standing, elevate legs above the heart, daily walking, avoiding trauma, and daily foot and leg care. And I'm sorry, but that's my cat saying hi. Interprofessional and nursing care, wound care and dressings. Remember, we want to keep the wound bed moist. We want to make sure that they receive adequate protein, vitamins A, C, and zinc. We want the diabetics to have normal blood glucose levels. Remember that A1C is close to 6 as possible. Monitor for infection. Drug therapy, make sure that we have provided that it's timely. We're not late or too early with drugs. Sometimes the patient may need a skin graft. And then, of course, daily moisturizing of the area is critical. So that's the end of this section. And I do apologize that these lectures are going to well over an hour. But there's a lot of information here, and we want you to grasp them even more. Remember, this week we have 3 videos for you to watch. And now move on to the 3rd one. But thanks for listening. If you have any questions at all, make sure to ask your faculty member so that I can address your concerns or questions. Take care.